All right, home stretch. We're almost done. It's lovely, actually, and we're going to take a little tour this morning through your colon, just to kind of get you started on the right foot this morning. We're going to talk about your colon. So there's a lot to cover in the lower abdomen, particularly in your gut. So let's talk about lower GI stuff, and we're just going to blast right through here. Lower abdominal pain, the things that can cause it are legion. And to be honest, I hate differential diagnoses like this. I hate books that put these long laundry lists of things, of anything that could possibly be happening in your belly. What I really need to know is what's most likely to come see me in the emergency department. So what we're going to do is sort of traipse through all of the diagnoses that might be related to the colon that come into the emergency department, sort of what we're going to go through. A couple things about this. Gastroenteritis, which we see. There's no question. We see acute gastroenteritis in children, and we see it in adults. It is gastroenteritis. It's an upper problem and a lower problem, and it's usually viral. It's usually not a big deal, but a lot of things can come in looking like gastroenteritis when they're not. So anytime, I have a habit of anytime I have gastroenteritis or AGE coming out of my pen or coming out of my fingertips as I type on the computer, I make sure I take just a second, take my fingers off the keyboard and just rethink it and make sure that it really is just that. If it's an older person, that I've thought about all the scary things. If it's a pregnant woman, I've thought about the scary stuff. I just go through the laundry list in my head of the scary things that could be causing their trouble, and then they're on their way. Often it is just gastroenteritis, but it is a common diagnosis that's on the chart when we've made a mistake, where we've missed something that's serious. Often it's appendicitis that we've missed. So we see it a lot, it's a real deal, it's very common. Just take that one step and think it through before you actually put that on the chart. It's kind of just a garbage diagnosis. And I'll tell you honestly, you're probably better off, instead of writing gastroenteritis down on the chart, write the symptoms. Vomiting. You get reimbursed for that. It may not get reimbursed quite as much, but you get reimbursed for that, and it's more accurate than labeling something that you're just not exactly sure. So just know this is a bit of a pitfall for us, and this is a place we get in trouble, and I'll tell you which diagnoses as we go through that we get ourselves in trouble with on that. Now, constipation is a common problem. We actually honestly don't see it a super lot in the emergency department. I think this is something that people go to the pharmacy and ask about enemas, etc. But you can see it in the ER. The key is to make sure it is just constipation, that it isn't something more serious like a bowel obstruction that's causing someone to have, they just can't stool. So just your job is to make sure it's just constipation. And I'll tell you, the reality is that constipation can be lethal. Sounds ridiculous, but it's not. You can end up with someone, especially somebody who is sedentary, on a narcotic, especially somebody who's a little bit altered. So you take a nursing home patient who's a little bit out of it, who's on a narcotic because they have cancer pain, and they sit around all day long. They can get a ginormous impaction, huge impaction. And if an impaction is big enough, it can distend the bowel and perforate it. So constipation, when it's truly impaction, can be lethal. It can be, and I'll tell you, the nurses hate you if there's an impaction patient and you need to deal with it. They hate you, but sometimes you have to. Sometimes you need to. I have to tell you a story. If any of you went to the American College of Emergency Physicians meeting in Seattle last year, one of the things that happens when you go to that meeting, if you're registered, is they put these little things called doctor bags on your door every day. It's all about exhibits and things. But in your doctor bag are all these brochures and pamphlets, etc. And then this year's doctor bag, somebody has invented a disimpactor. It looks sort of like a turkey baster with little these soft rubber flanges that stick out the side that you're supposed to apparently just kind of stick up there, kind of ream it around a little, and I guess that's how you're supposed to. Both my husband and I, we put him on the table. It was like, oh my God. And I really wonder what the cleaning people thought when they came to clean our room. I think if you saw that in a room here, you wouldn't think twice. But if you see that in Seattle, it's like, what is this thing? Disimpaction is a real deal. Sometimes you need to do it in the emergency department, and especially in somebody who's on narcs, you can feel just this ginormous stool ball in there, because know that impaction can be a big problem. It really can be. Take them to a private room, make sure you buy the nurses donuts the next shift, but it can be a big problem. Now, infectious diarrhea, take the other extreme, where people are pooping like crazy. We see lots of cases of diarrhea, tons of them. Often it's viral. You know that most of the cases we see are viral. Vastly, and rotavirus because the vaccine is getting less and less in kids, but we see tons of viral diarrhea. We see it all the time. Lots in kids, lots in adults. And viral diarrheas, you don't have white cells in the stool, they often don't have much of a fever, they're really not usually tender at all. Okay, it's basically just pooping quite a bit. Often it's sort of viral season. A couple of people in the family may have the same thing. We see that a lot. We worry about the invasive diarrheas. Now, the invasive diarrheas tend to be the bacterial diarrheas, and they can be a really big problem. Typhoid fever is a real thing. I was just talking to a gentleman here in the group who was working in Nepal. He sees tons of typhoid fever. So that we see this even in the United States. If they're febrile, if they're tender, if their white count is high, if they're tachycardic, all the things, they're sicker. They're just sicker. They may have red cells in their stool, so they're occult blood positive. They may have white cells in their stool because it's an invasive diarrhea. These are the ones we worry about. Shigella is the one that causes seizures. Okay, that can cause seizures particularly in children. Salmonella is a problem because it likes to live in the gallbladder. Even if you treat them, they can end up with carrying the salmonella around for a while. And the most common one is Campylobacter. We have a carniceria across the street from the hospital where I work that cooks the most amazing food. It's fantastic. Until we bought food for the whole ER, and it turned out to be laced with Campylobacter. We wiped out most of the ER for a couple of days. We all got sick. Everybody got sick with Campylobacter. So Campylobacter is an issue. Now, toxigenic is what's going to ruin your vacation. So you take your pristine American bowels to somewhere that has E. coli, like we all have E. coli in our bowels all the time, but has a toxigenic E. coli. And you have so you know you're not supposed to drink the water. I'm smart. I'm not going to drink the water when I go down to Mexico. But you have your margarita, your blended margarita. That blended slushy stuff is ice. That's water. Hello. It's in the ice. So now you feel great on Friday. It's the first day of your vacation. Saturday, something's a little funny. Sunday, Montezuma's revenge. You are now in the back. It's like gurgle, gurgle, gurgle. Oh, here it comes. That's toxigenic E. coli. What it is that you've ingested it. It goes down and lives next to the E. coli that you have in your bowel all the time. But as it starts to proliferate in your gut, it doesn't make you sick as far as invasive. What it does is releases a toxin. So you end up with lots of watery stools, you hardly ever have a fever, you're not tender, you're not really even throwing up, you're just pooping like crazy. It ruins your vacation. So that's the toxigenic E. coli. You treat it, okay, you can actually give antibiotics, it goes away. You can make your vacation much better. But know that that is truly an infectious diarrhea, but not an invasive diarrhea, okay, that causes the traveler's diarrhea. Really common, really, really common. And if you travel to developing countries, you may get some of the weirdo stuff. You may get some parasites, you can get some of the other stuff, absolutely can get worse things. But in general, in the places most of us travel that are more developed, you get toxigenic E. coli. Now, staph is another toxin. Staph is sort of the traditional, the picnic on Saturday, you're out playing volleyball, the potato salad is sitting out in the sun. It now basically, all that lovely mayonnaise starts to grow staph. The staph releases a toxin. The potato salad tastes great. It just has a toxin. And that evening, 6 hours later, you're in the bathroom. You are pooping like crazy. You may actually have nausea and vomiting with that one as well. That again is a formed toxin. You are not febrile, you are not tender, you just are pooping and maybe vomiting like crazy. So those are sort of the general categories: viral, invasive bacterial, traveler's diarrhea, which is toxigenic E. coli, and the toxin related. So those are sort of the general categories. You can often make the diagnosis just on the history. Oh, you were just in Mexico. Oh, you were just eating potato salad at a picnic yesterday. You can often make the diagnosis based on history alone. Whether you do additional studies really just depends on the patient. So in cases of toxic bacteria, toxic diarrheas or viral diarrheas or some of the, like the traveler's thing, you don't send cultures. You don't need to. But the sicker they are, the more things you're going to send. I'll tell you in general, from the ER, you're not going to send any testing for ova and parasites unless someone has been sick for more than 2 weeks, they're immunocompromised, especially HIV, or they have traveled to an endemic country where they may have picked up something terrible. Otherwise, you don't send O&Ps in the ER. So stool cultures and O&Ps don't go together always. In fact, they rarely go together. But you do want to send stool cultures in somebody who's sick with their diarrhea. They're tender, they're febrile, their white count's up. That's a person you want to send it because it makes a difference, especially if they happen to be a healthcare worker or a food industry worker. Because that person, these are fecal oral transmitted. This person, if they don't wash their hands well, can spread it to everybody. So you've got to be really careful with these folks. You'd like to know what it is so you can tell them when they can go back to work in those kinds of folks. In adults, if they're not super sick or it's traveler's diarrhea, you can basically slow them down, so give them something like loperamide, and you can give them antibiotics. I highly recommend that if you are going to travel to Mexico or to a developing country, I have a little Ziploc bag with all the things I need if I travel. I always have loperamide. I always have at least 2 antibiotics, one for skin stuff, one for gut stuff. I always have Dermabond in case I happen to get a cut. Got Dermabond for that little Ziploc bag of all the medical things I might need. Antibiotics will, if you get that traveler's diarrhea, you feel that kind of gurgling going on in there, take your first dose of antibiotics right away, because it will shorten your illness to as short as 24 hours, so you don't end up ruining your vacation. It works great. Now, I'll tell you, the sicker the patient is where the controversy comes up with giving antibiotics. The Infectious Disease Society of America says, don't treat them. The problem I have with that is I have a septic patient in the emergency department who has an invasive diarrhea, who is really sick. There's no way I'm not going to treat that. Okay, I'm also obligated by the sepsis guidelines to do the right thing for sepsis. The other thing is, as an outpatient, I don't have to admit everybody I think has an invasive diarrhea. But if they're a little bit febrile, their white count's a little bit up, they're otherwise keeping things down, they're doing all right, maybe some stool white cells, I may send that one home, and I often send them home with antibiotics. I'm breaking all the rules, but the reality is I get one shot at these folks. Yes, they will probably get better on their own. I don't know that. And I know that the antibiotics will work to help them. So this is a little bit of controversy. The sending home what you think is invasive but not that sick diarrhea patient, I like antibiotics, but I'll tell you, there's a lot of controversy on that practice. Admission, if they're sick, I think antibiotics are indicated, despite what the IDSA says. All right, as we traverse through our bowel, as we get to the ileocecal valve, we run into the appendix. And appendicitis is extraordinarily common. Extremely, extremely common. You basically have this vestigial organ, theoretically vestigial, it actually may be more important than we think, but this little organ, this little thing that's sticking off the edge of your cecum, and it gets basically a stool ball. It's called an appendicolith there. It gets often calcified, and you get just things that jam in the neck of that appendix, and it gets inflamed. It gets overgrowth in there, it gets inflamed in there, and you end up with a true appendicitis. That's the pathology in 80% of them. About 20%, there's no obstruction at all. We don't know why it happened. About 20% of the time. And the classic history, which of course, if it's classic, it means it never happens. But the classic history is pain goes from here to here to here. That's the classic history. And when you examine them, they're tender just down at McBurney's point. It would be lovely if patients would read the textbooks. They just don't. The patients don't read the textbooks. And I'll tell you, the people who don't read the textbooks are the pregnant, the young, and the old. Okay, the pregnant, the young, and the old don't present like you would expect them to. What is consistent in almost everyone, though, is tenderness in the right lower quadrant. So your exam really trumps everything when somebody comes in who might have appendicitis. It's really important. They may have diarrhea, they may have constipation, they may be eating, they may not be eating. All that other stuff. Let me tell you a story. My husband's daughter, very smart, 32-year-old, lovely, skinny, little, gorgeous thing. She called, I hear, this is the end of the conversation I hear. My husband's on the phone with his daughter. I hear the following conversation. Really? Where when you push? Your right lower quadrant. Okay. So do me a favor. Get up. Jump up and down. Where does that hurt? Your right lower quadrant? Did you eat? You did. You had a hamburger. Jump up and down again. Where does that hurt? Your right lower quadrant. Get to the hospital. She had a full meal. She had a normal white count. She was starving when she went there. The only symptom she had was some vague right lower quadrant discomfort that hurt when she pushed and hurt when she jumped up and down. She had raging appendicitis. Do not expect people to do the right thing. She did have the tenderness where the appendix was, so don't expect them to do the right thing. Do all your lovely obturator signs, psoas sign, Rosving signs. It makes you look fancy and smart. But if they're positive, great. If they're not, they still may have appendicitis. Appendicitis is a wily diagnosis. It's difficult. To work, and kids are where we miss this. The younger the child, the more likely we are to miss it, and the more likely they are to be perforated. So kids, this is a big, and this is where gastroenteritis in children, honestly, please, if you write it on the chart, really think about appendicitis. Go back and poke on that kid a couple times. Poke on that right lower quadrant a few times before, not once, do a repeat exam and a repeat exam, because it's almost always gastroenteritis on the chart when the kid comes back with a perfed appendix. So it's almost always on the chart. Now, imaging, what do you do with these kids? Or what do you do with anybody who has appendicitis? So the other end of the conversation I hear on the phone when my husband said, go to the hospital, is he said, don't let them scan you. You're slim. Your appendix should be very visualizable with an ultrasound. You tell them, no CT, I want an ultrasound. They got an ultrasound, they found appendicitis, she was in the OR within 6 hours. The ultrasound, there's no radiation. If somebody's slender, if it's a kid, if they're pregnant, you can sometimes see the appendix, and they're getting better and better and better at this. So really consider ultrasound as your first go-to, especially in kids. It is the absolute go-to in children. If you have an ultrasonographer who knows what they're doing and they're getting better and better, get an ultrasound. We often do a CT, but I'll tell you, we're radiating. Think about the people who get appendicitis. I mean, it's a lot of young people, and they have 50 or 60 years left on the chassis that you've now just radiated. So CT scans, although helpful, really should kind of probably be relegated to second line if you have the option of getting ultrasound. MR is something that's been talked about in pregnant women so that you don't have any radiation to the fetus or to the mom. If you're trying to get a CT scan. The data on MR is promising, but I'll tell you, I just talking to one of the people in your group here, the MR, there are protocols for things like PE and appendicitis in pregnant women. A lot of places don't really have an MR protocol they're comfortable with yet, or don't have the experience of reading the films themselves. So just know MR is in there. And if you have a group that's comfortable with it or a place that does it, good on you. But overall, I think the order probably should be ultrasound, CT, and then MR if you have the option. I'll tell you, at the very tippy top, put nothing. If you have a 20-year-old guy who has tenderness in his right lower quadrant, a white count, has no appetite, McBurney, he needs to go to the operating room. He doesn't need he doesn't need anything else. He needs to go to the operating room to get taken care of. Now, I will tell you, though, one thing that's changing is they're not operating on all these people anymore. So we have a protocol now where some of our appendicitis cases are just cooled off and left alone. They're not operated on, which it's a little bit interesting. I'm not sure. It's a pretty benign surgery. You're up and out and back to work in 2 days because it's laparoscopic. It's a pretty benign surgery. It gets rid of the thing forever, so you don't have to worry about it. But I will tell you that there are protocols now that have nothing to do with antibiotics or with the surgery. They have everything to do with antibiotics and just cooling them down. And if they've perforated, which remember, a lot of kids do, a lot of elderly do, they actually perf. And what happens when they perforate is oh my gosh, it's so painful. So, I feel so much better now. Because it's all now running around loose in there. And once they start to get the peritoneal inflammation from spilling all that crud in there, then they get sicker again. If they've perforated, often they don't operate. They do chill them out. And they may, if they have an abscess, do that IR drainage. They may not do surgery. So there's lots of options now. Our job is, I think, get antibiotics on board and get on the phone. And let the surgeon decide and the IR people decide what they're going to do about it. But I think antibiotics are indicated, definitely if they're perforated. Okay, so that's sort of our appendicitis deal. The other thing that can happen in your gut that's sort of an inflammation infection thing is diverticulitis. Now, a lot of people, if they've gotten their healthcare maintenance stuff and they've had their colonoscopy at the age of 50, may know that they have diverticular disease. It's extremely common. Okay, it's very common, especially in the Western United States, where we have a diet that's not terribly great for our guts. And you end up with these little outpouchings, these little, it looks like, have anybody ever seen Brussels sprouts in the raw? Not in your store. Brussels sprouts come on a trunk. And they basically are just these blobs that stick on the outside and they slice them off and sell them to you in the store. What diverticular look like is Brussels sprouts out in the wild. It's basically your colon with all these bubbles sticking off the sides because it's actually these outpouchings of the wall of your bowel. If you get a little stool ball, I love that picture. It looks like a malted milk ball. That picture, if you get a little stool ball that gets stuck in the neck of one of those diverticula, it's going to do exactly what your appendix does. It's going to get all inflamed, you're going to get overgrowth of bacteria, and they're very likely to microperforate. They can macroperforate. They're very likely to and we diagnose these very commonly now by CT, and the CT looks like all these little bubbles are sitting around the outside of the colon, the large bowel. They're usually on the left. You can have them on the right, but most of them are on the left side of the colon. It's where sort of the pressure gradient is appropriate for these little outpouchings to occur. If somebody gets diverticulitis, and what they tend to present with is what you know, which is I have some left lower quadrant pain, it feels a little bit worse when I stool, and then it feels better. They tend to have symptoms that they're a little tender there. If somebody's mild and they know they have diverticular disease, so yep, I had my colonoscopy and my gastroenterologist said I have those bubbles on my bowel. And now I'm tender, but my white count's not that high, I'm not that tender, I'm not vomiting, I'm otherwise doing okay, you can treat that person as an outpatient. Okay, you don't even necessarily need to, I wouldn't actually in that person CT them. I know they have the disease, they told me they have the disease, it fits the history, and they're not that sick. They're gonna go home with antibiotics and stool softeners. That's what they're gonna go home with. If they're sicker though, that is the person you're gonna wanna image. Or if you're not sure of the diagnosis, that is the person you're gonna wanna image. And the sicker they are, the more likely that you're gonna get studies done and need things like antibiotics IV in the emergency department. Know also that the treatment for this is changing. If somebody has an abscess, what they're doing now is IR drainage if it's under a certain size. Okay, IR drainage, letting them chill out, going in and taking out the portion of bowel that's involved, and then sewing it back together primarily. So it's actually kind of nice. People are not ending up with colostomies forever. They're getting a single-step surgery if this is done right. So our job, again, is to diagnose it appropriately. You don't have to image them all. You don't have to admit them all. And again, the sicker they are, the more likely you are to image, admit, and give antibiotics IV. Now, as we get down to the lower part of the bowel, two things can happen that are kind of unusual and kind of interesting. One is sigmoid volvulus. So the sigmoid colon is this kind of big, patulous, and it's a storage system, is all your sigmoid colon is meant to do. It's meant to store stool until you're ready to get rid of it. What can happen if you are constipated all the time, or if you are sedentary, for instance, a nursing home patient that has constipation, what can happen is it gets kind of floppy and it turns on itself. And it causes a volvulus. And the best way, I think, to remember how these are, how they work, is think about balloon animals. So if I had one of those long, skinny balloons up here, and I blew it out, and then I took it and I made a loop of that balloon, that's sigmoid volvulus. It's a big loop of bowel that twists on itself. It gets obstructed as a result, and if it twists tightly enough, it can compromise its blood supply. So you can end up with two problems. You can end up with not just volvulus, you can actually end up with ischemia on these. These are basically usually diagnosed either plain film or CT, often CT because they want to know that twist point, but plain film gives you, I'll show you a picture, plain film gives you the answer in most of these cases. And this can be fixed with endoscopy. They can actually do just a sigmoidoscopy, and as they get in there, they can untwist it, and they can take care of this without having to do surgery. This is what it looks like. There's that big twisty loop of bowel. You can see where it's kind of pointing down at the bottom. The twist point is the left lower quadrant. The top of that loop is the right upper quadrant because that loop is just twisted on itself and now it's all blocked. Versus cecal volvulus. So that's older people, okay, end of your bowel. This is different. Cecal volvulus, now we'll take our balloon animal again. Let's take that big balloon. And then instead of taking a loop of it and twisting it on itself, take the end and twist it. That's what your cecal volvulus is like. It's not a loop, it's just a single ball of air that's twisted. And it's different. This is a different group of people. This is pregnant people. This is guys more than women. And this is people in their sort of 20 to 50 age range. They will present basically with usually initially colicky and then constant abdominal pain. And what you end up with looking at is that. Okay, there's the cecum, that end of bowel, that bottom right picture is kind of nice. It shows you the cecum is twisted on itself. It ends up with, instead of a big old loop, it ends up looking like a little kidney. Okay, it looks like a kidney. That is, and it's in the right lower quadrant. That's the cecal volvulus. That's a surgical emergency. The only way to untwist that thing is to open somebody up and untwist it. So sigmoid, they can do through the rectum. Cecal, they need to do that through surgery. Now, as we get down to kind of through the bowel, one of the things that you can get from stem to stern, from your esophagus to your rectum, is Crohn's disease. It's called regional enteritis, and it's sort of known for skipping parts of your bowel. You can end up with an ileitis and a colitis and an esophagitis. It's Crohn's disease. It's one of the two big inflammatory bowel diseases that we see. They present with pain, fever, diarrhea, often bloody is how they present. So it looks like an invasive diarrhea, but they'll say, you know, I've had this 3 times. How weird is that? Or, you know, this has been going on for 3 weeks. Invasive diarrhea doesn't go on for 3 weeks. So that's how the Crohn's disease patient tends to present. We don't usually diagnose it de novo in the ER. Often they come in and say, I have it. But you will suspect it in somebody who's had bloody diarrhea for too long, or who's had several episodes where it doesn't make sense. Or they have what you do imaging and part of their ileum is inflamed, a part of their colon is inflamed. Then you're going to worry about regional enteritis. This is usually worth a call to a gastroenterologist because the management is not our usual management. Steroids are what you use. Each person has different doses they want. Some people want antibiotics. Worry that they may still have something like appendicitis because they can mask it. So that's the regional enteritis. Again, that's top to bottom versus ulcerative colitis, which is just the colon. So it's another inflammatory bowel disease, but it's just the end. It's just the colon itself. On this. This is young people. Both of these diseases, by the way, increase the lifetime risk of cancer significantly. 30-fold if it's ulcerative colitis. So they get surveilled all the time. They get scoped on a regular basis to make sure that they're not developing cancers. And again, this is also something where they come in with bloody diarrhea. It can last a while, and it's often a phone call to the specialist to say, how do you want me to manage this person? Or the patient may know. Every time I get a flare, they put me on this dose of steroids and this dose of the immunosuppressant. This is what I usually take. So the patients often know their own disease. Now, bowel obstruction is very common. And bowel obstruction, we see the two main reasons people have bowel obstruction. The most common reason, no matter how old you are, is that you've had surgery. If they muck around in there, they open you up and they muck around in there, you're going to get scarring. It just happens. And your small bowel, there's 60 feet of it, is squirming around in there, and a little loop of it gets stuck behind a scar. And you get small bowel obstruction. I'll tell you the other reason people get small bowel obstructions, though, is hernias. And please, please, please look for hernias, especially in the elderly or in somebody who has a small bowel obstruction and they've never had any surgery. Look for a hernia because often we miss it. And if you miss it, the mortality rate skyrockets on these folks. So lots of reasons people get it, but usually it's post-obstructive or it's post-surgical adhesions, and remember hernias in these. We confirm this often by plain films. Plain films show this sort of stair-step pattern, and it makes sense that it's stair-step. If you think about what's happening in your gut, there's a place where it's blocked, but the rest of your gut's still doing its job. So your small bowel is squeezing stuff that you just ate all along, and it's sort of like a slinky. It's going to squeeze some fluid over an obstructed, if I'm upright, over an obstructed loop, and I'm going to have air fluid levels of different heights. They're not going to all be the same across because it's squeezing. It's like that slinky. It's trying to squeeze stuff across. So on a upright plain film, I'm going to see stair-stepping of the small bowel. And the small bowel is that one that looks like a stack of coins. It has plicae circularis. It has basically a muscle layer all the way around the tube like a stack of coins. So they're called plicae circularis, and you'll see this sort of stacking of coins with these uneven levels. Now, can you do a CT scan to diagnose it? Absolutely. And I'll tell you one of the things about CT scans is a lot of surgeons are asking for them because they want to know the point. They want to know where is this thing obstructed, because sometimes they're doing laparoscopic surgery. They can go right where they found the obstruction on CT and just release that adhesion and take care of somebody with a minimally invasive surgery. So CT scanning is actually becoming kind of important when it comes to small bowel obstruction. Here's the stair-stepping patterns you can see in that middle x-ray. You see sort of this loops of bowel where things are a little bit stair-step. The left x-ray is a classic picture of obstructed small bowel, and your CT scan's there on the right. You treat this as NG tubes. Things aren't going that way, so take it out this way. So take it with, stick an NG tube down there, make sure that you pull everything up from above, pain meds if they need it, and usually you just call the surgeon is what you need to do. Now, large bowel is different. Large bowel obstruction is malignancy. It's most of the time malignancy. If it's not malignancy, it's a diverticular abscess, and then everything else falls way down the list. So somebody who comes in and you look at their x-ray and their large bowel is obstructed, and the large bowel doesn't have those plicae circularis. It doesn't have that stacking of coins. They have haustra, which come in only partly through the wall. So it ends up looking like a stack of bricks, is that what the large bowel looks like. Those things don't go all the way across. That's large bowel obstruction. And plain films are diagnostic on these frequently, and CT is done just to look mainly to find is it an abscess or is there a malignancy in there that's causing trouble. These are surgical. Okay, these are surgical. They often need to go in and relieve the obstruction and deal with whatever's causing it, not infrequently something like cancer in that middle picture. Now, you can also have a bowel obstruction that's not really an obstruction. It's just that your bowel is resting or not working right. The most common reason people get adynamic ileus is post-op. Anybody who's had surgery of any kind, they come and ask you every 3 seconds, have you passed gas yet? It's like, please, do you really have to ask that every 3 seconds? The reason they're asking that is they want your bowel to start working again. That's one reason that your bowel may be resting. But the other reason your bowel may not be working well is because you're sick. You're septic. Certain medicines will slow it down. Often it's just because you're sick. In those cases, what's happening is your bowel isn't squeezing anything. So you'll see air fluid levels, but they won't be stair-stepped. Everything just sits at kind of its own flat level. They're not stair-stepped at all. So what you'll see is something like this. Okay, it's just not working. Nothing's going anywhere there. That's basically adynamic ileus. Mesenteric ischemia is life-threatening, and if you don't think about it, they'll be dead. Mesenteric ischemia is characterized by pain out of proportion to exam. Any ischemic pain is characterized by pain out of proportion to exam, testicular torsion, you name it, any ischemic pain. But these people usually are vasculopaths. So they have atrial fibrillation, they have coronary artery disease, they have cerebrovascular disease, and they come in with severe abdominal pain, often abrupt in onset. I was fine, then I wasn't. I am miserable, but you can palpate like crazy. That's somebody who threw a clot. Okay, that's mesenteric ischemia because they're not on Coumadin and should be, and they threw a clot from their atrium and they're necrosing their bowel. You can also get it from a clot de novo that forms in situ. You can also get it from a low flow state. I'm septic, my systolic blood pressure is 60, my belly hurts because it's not perfusing my gut very well. Ooh, you resuscitate me, my systolic's 100, now my belly pain is gone. Okay, that's transient. It's not that doesn't tend to kill people so much, but I'll tell you, the emboli really do. Again, vasculopaths, older people, pain out of proportion is the finding. The key to this is get a surgeon. Okay, you're gonna go ahead and get a lactate, check for metabolic acidosis, all that other stuff. But if you think it's mesenteric ischemia, you have 6 hours, and they're dead. 80%, 85% mortality rate if it's an embolism. So get a surgeon involved. And they usually look awful. They usually look miserable. So abrupt onset, severe pain, please think about it. Don't wait for testing. Go get a surgeon involved. If you really think that's what's going on, you can go ahead and order the testing, but let them know early, again, because the clock is ticking. CT with IV contrast in the right kind of protocol. Tell them what you're looking for. They'll time it right. That's the way you make the diagnosis. And surgery is the way they take care of this. They have to take it out, take the gut out that's necrotic. We're almost done. Hernias. Hernias can happen all kinds of places. We think about them in the groin, right? Direct and indirect. Indirect goes down into the scrotum, direct is up above. Women can get femoral hernias. Okay, that's actually into the femoral canal. You can get ventral hernias, umbilical hernias, surgical scar hernias, and what's not in this picture is Sphegallian hernias, which are the lateral aspect of the rectus abdominis muscle, all over the place. The reason that's important is if you have somebody with a small bowel obstruction, they haven't had surgery, don't go just for the groin. Okay, go for the groin, that's where most of them are, but look all over the place. Feel for other places and see if you find a hernia someplace else. These things, if they're incarcerated, it means that they are stuck, they can't get back. That's a problem, but that's not life-threatening. If they are strangulated, that's life-threatening. Okay, that bowel will die. It's in there, it's stuck, and its blood supply is compromised. So incarcerated means it's stuck out there. People can walk around with incarcerated hernias for the rest of their lives. There are guys that have inguinal hernias where it's out there, it never goes back in, but it's not causing them any trouble. If it gets strangulated, that's the problem. Now, bowel perforation we see also, the risk group for this is people taking non-steroidal anti-inflammatory agents, which is why you got to be careful giving that non-steroidal to an 85-year-old, because they may perforate their bowel because that little thing erodes right through. Proximal perforations will show free air. Distal perforations may not. So say my diverticulum perfs instead. That's what perfs this time. They may have little focal sort of loculated pockets of air. It's not free all over the abdomen, which has put CT scan higher in making this diagnosis. You can do plain films. So if you see that chest x-ray with those lovely 2 dark streaks underneath the diaphragms, that's somebody who has a significant perf, usually proximal, often sort of small bowel or stomach. That's a big perf. This often, though, is the way we make the diagnosis. This is somebody who has basically little pockets of free air in their belly, and this is often distal, where they have this. This is a surgical problem. Okay, you call the surgeon in these, get them involved. We are going to end with the anus. It makes sense. We're at the end. We'll end with the end, which is thrombosed external hemorrhoids. So on my list of things that I think are cool, I'm an ER doc. I already told you about shoulders. I already told you about SVT. Love those. Love draining abscesses. It's like a big zit. Love draining abscesses. And thrombosed external hemorrhoids, getting rid of one of those, awesome. You can tell the person who has a thrombosed external hemorrhoid. They're sitting out in the waiting room on their one cheek. Because if they sit straight, they're sitting right on that thrombosed hemorrhoid and it hurts like a son of a gun. It's an external hemorrhoid that basically is clotted off. And it hurts like so they've gone from that itchy, burning hemorrhoid to, wow, it really, really hurts. A couple things about thrombosed external hemorrhoids. First of all, make sure it's thrombosed. Okay, make sure it's thrombosed. And it's best if it's a fresh thrombosis. It thrombosed today or yesterday, not last week. Because if it thrombosed last week, it's going to be organized. It's going to be hard to get that clot out. If it's fresh and kind of goopy, that's the perfect thing to actually try to take out of there. So first, make sure it's thrombosed. The worst thing you can do is cut open an external hemorrhoid that hasn't thrombosed, because it's like the Red Sea. It's like, oh, whoops, sorry. That's why you take the 4x4s, you cram them in the crack, you take the tape, you tape their butt together, and you just cross your fingers and hope it stops. Most of the time, fortunately, we're good enough at figuring out what's what. If you do need to get rid of the thing, raise a wheel of lidocaine or BPEG, whatever, over the surface, and then cut an ellipse out that is going radially away from the anus. So the point of that ellipse is is pointing to the anus. Cut an ellipse out, birth out that clot. Magic. They feel better instantly. So make sure it's thrombosed. Be careful if it's not, don't cut it. If they're coagulopathic, you might want to think twice. If it's too old, it may be organized and it may not come out at all. You do is make a cut, nothing happens. But it's a wonderful thing to help take care of people. All right, we're done?